assessments, the people on the ground are not part of this. And I think he has underscored critical point that for us to undertake successful integration assessments, we need the researcher, the manager, and I add a third group, the provider, to be part of it, so that there is utilization of the results of such assessment. Ian has brought to the fore the issues to deal with impact of evaluations of integrated approaches, especially with regard to key populations. One of the key populations that we talk about here is, for instance, men having sex with men. How do our integrated services address their needs? Specifically, we have mentioned people living with HIV. How do we assess the impact of our integrated services on the SRH needs of people living with HIV? How sensitive are our services, and how do we document that and demonstrate that actually what we sought to do is happening? In terms of comparison, I think you'll see a lot in the conference about efficiencies, effectiveness, and there's a lot of work that's being done on cost effectiveness of integrated services vis-a-vis vertical services, and also cost efficiency. And I think this is very critical for us who are driving the integration agenda, because at the end of the day, the policymaker, the people who are allocating resources, will ask you, how much does it cost? Is it cheaper than the vertical services? What is the rationale for us to go into integration? There's a lot of anecdotal evidence. Service providers will tell you, yes, it works better, clients are more satisfied, but I think from Ian's presentation, there is need for us to indeed demonstrate that, with evidence that indeed it works. There's an aspect that he has mentioned that a lot of us ignore, documenting feasibility. I think that's very critical. A lot of us from that corner of the room to the other corner are starting to do the same thing that my friend Otanina here is doing very well. But then because he has not documented the feasibility, we are very busy reinventing the wheel as it were. So I think it's very critical that whatever we are doing is documented so that the rest of us can be able to learn, so that we avoid duplication, and we are able to demonstrate for those who want to replicate this elsewhere or scale it up, what are the building blocks? I think that is very critical coming from Ian's presentation. Thank you very much. I take this opportunity now to welcome Kevin Osborne to take us through reaching out to key populations through integrated services. Welcome, Kevin.
Good morning, everybody. I don't like standing behind one of these things, so I'm going to use this microphone. I'm going to walk a little bit. It's my Oprah Winfrey moment. Okay, so today we're going to talk about key populations. And I'm specifically going to define the key populations because I think there's a lot of questions around terminology and target groups. And for a whole lot of historical reasons linked to the HIV epidemic, I've specifically defined key populations as men who have sex with men, sex workers and their clients, and people who use drugs. I've purposely not gone into migrants and prisoners for a whole lot of historical reasons, which I'll go into a little bit later. So this presentation is going to specifically start asking the question, does integration work for those populations in generalized epidemics in sub-Saharan Africa, or is that a bridge too far? And I have a hypothesis about what we should or shouldn't be doing. You'll see that there is a promise of what linkages should do. And you'll see the promise on the board, on the slide. But there are 4 promises that linkages say they would do. And the 4 that I've highlighted there touch on individuals. It clearly said, if you integrate services, we could reduce stigma and discrimination. That was one of the promises. So for key populations, it means I can come to a service. Nobody will know why I'm here for an HIV service or an STI service, so there's no stigma. That's an individual promise. The second one is we said if we'd reach more coverage. We all know that coverage for services for key populations is incredibly low. So would integration increase that coverage, i.e. helping individuals again? The third one is around rights. And the fourth one, he said, we make better utilization of services for those people. So I've highlighted 4, and I think that's the promise. And my question to you, no matter who you are, is that promise being kept? There are 7 principles that have been agreed by UN agencies, international declarations that we spoke about yesterday, and again there are 3 that I'm going to highlight. One of the principles was it said, integration should foster community participation. Who is that community? Is it a selected community? Is it communities most in need of sexual and reproductive health and HIV? The second one was around reducing stigma and discrimination, and the third one was around the centrality of sexuality. So we know that there's a promise, a hope of what it should do. We know that there are guiding principles. So why has it not happened? I think in sub-Saharan Africa, and maybe even globally, people will go, integration works best in Africa because it's a simple thing to do. It's easy, it targets women, maternal health programs, the obvious link is EMTCT or PMTCT programs. So there's what I'm calling the stereotypical response. And maybe a lot of the evidence that's generated goes to that exact stereotypical response of women and girls in Africa, maternal health. So what do you do if you're not pregnant? If that's not part of your reality? Do we leave you out? Does integration not work for you? And often we've seen, and I think it's been borne out from a lot of the presentations yesterday, is we've always said linkages should be bi-directional. It should be everybody on the HIV side saying, my HIV program shouldn't stand alone, it should incorporate some sexual and reproductive health. But similarly, the sexual and reproductive health program should incorporate some HIV. And by and large, we've seen from the rapid assessment tools that the level of effort is predominantly from the sexual and reproductive health community taking on HIV work. And with a few notable exceptions, the HIV community has largely not done as much reaching out to embrace sexual and reproductive health issues in that spirit of bidirectionality. Ian spoke about the evidence and what do we generate. And I'm just saying, perhaps as researchers and policymakers, are we sticking with the low-hanging fruit, the easy things? And I'm going to say that maybe family planning and integration of family planning, we know it works, and I'm not saying it shouldn't be done, it should be scaled up and done, but we know that. We know that today. There's no newness in that. Family planning, for example, linked with HIV prevention, education, and condoms, there was a review done. There's 54 peer-reviewed studies. There's a lot done. But when we start looking at questions around key populations, there's a dearth of evidence. Maybe it's being done, but we don't document it, or maybe it's not being done. So the missing gap, perhaps in this region, in generalized epidemics, is that we don't really like to concentrate or ask the question, does it make sense? And maybe the easy answer is it doesn't make sense and that's why it's not being done. Or maybe that's just the easy answer. We don't want to take that bridge too far to say, how do we make sure that promise of integration is realized for the communities I've listed up there? So for men who have sex with men, in sub-Saharan Africa, the prevalence rate, the estimated prevalence rate amongst men who have sex with men is 17.7%. In Kenya alone, the prevalence rate is estimated at 15.2% in this country. So the burden of HIV amongst men who have sex with men, compared to other men who are not men who have sex with men in Kenya, which is at 6.1%, shows that men who have sex with men here have a huge disproportionate burden of HIV. And therefore, if there's stigma, if there's discrimination, if there's lack of supportive policies, maybe integration is the exact bridge that will address that discrimination. If laws and policies and people are not making it happen. In terms of sex work, we know that in this region, 36.9% of female sex workers, that's the estimate in this region, 36.9%. So in all countries in the region with data, we know that prevalence rate amongst female sex work is incredibly high. Where there's no evidence or there's no data amongst the rate of HIV in sex workers who are either men who have sex with men or transgender. In terms of people who use drugs, the estimated prevalence in sub-Saharan Africa is somewhere between 10 and 15%. So I'm sure we all agree that the numbers prove that something needs to be done. The rapid assessment tool that Ian spoke about, a lot of people spoke about yesterday, has highlighted the need to do that, for countries to do something. But let me let you in on a little secret. It was supposed to be, as the title says, it's a generic guide, so countries can use it and adapt it. Without naming and shaming any countries, a lot of countries, when they did this, adapted out anything to do with MSM, or sex workers, or drug users, almost trying to obliterate the idea that they even exist in certain contexts. Therefore, you don't need integration, because there's nothing for it, because we didn't ask the question. In terms of people living with HIV, we've spoken a lot in this conference so far about the idea of saying, how do we address in a rights-based way the sexual and reproductive health needs of people, of women, of men living with HIV? And yes, there's been great movements in trying to address it, but potentially there's problems on the horizon. And some of those problems relate to the ideas of sterilization, forced sterilization, where it's not that direct, of coercion of women living with HIV to not have and fulfill their reproductive choices in the way that we say should be rights-based. So potentially there's a conflict here about trying to say, how do we make sure that from yesterday we saw that the figures for contraceptive prevalence rates amongst women living with HIV are low. How do we get it higher? But there's ways to get it higher in a really bad way. And so we need to make sure that there are policies that don't criminalize HIV transmission. So I'm just saying, while this isn't as bad as it is in other parts of the world, we need to be vigilant. We need to be vigilant that the policies are constantly supportive of women and men's rights and their reproductive choices if they are HIV positive. There are some glimmers of hope. So is nothing being done? Or are there places in Africa, in continents, in little places where we can see there are things being done? And I'm going to touch on 3 ones. And if you forgive me, the majority come from some of the IPPF clinics in these 3 countries. So I'm going to start off with looking at lesbians, gay, transgender, intersex people in Cameroon. And without me talking, this is the program's director from the Cameroon Family Planning Association. So I'll leave it up to Natalie, I hope. Let's see if this works. John, that's not bad.